discuss a bit more on the focus mainly on the ventricular arrhythmia, mainly on the PVCs, VT and VF, and also sudden cardiac death, and a bit of self-monitoring ECG device for discussion. So ventricular arrhythmia refer to abnormal heart rhythm originating from the ventricle of the heart. This arrhythmia occurs when there is electrical impulses that regulate the heart rhythm become disrupted in the ventricles, leading to irregular heartbeats. Okay, so the common type of ventricular arrhythmias include the PVCs or VT. It can be monomorphic, it can be polymorphic, or it can be ventricular fibrillation. So the factors can trigger the ventricular arrhythmia includes the acquired heart disease, congenital heart disease, any electrolyte imbalance, and any ischemic heart disease. Also, certain medication and stimulant also can trigger the arrhythmias. Okay, so more on PVC. PVC are basically defined as early depolarization of the ventricle that are not preceded by a P wave, meaning they occur before the regular heartbeat. So the PVC are characterized by the wide and abnormal QRS complex on ECGs, and in a structurally normal heart, they are usually benign, but in the presence of structural heart disease, they may indicate increased risk of sudden death. This was the study by the Goretner et al. In 2020. So in newborn, PVC it can be normal up to 20% in otherwise healthy newborns, and then the prevalence will decrease up to 2 to 6% in childhood and adolescence. However, up to 60% patient with congenital heart disease show ventricular arrhythmia with frequent ventricular ectopy by the study by Alexander et al. In 2000. And then Barman et al. Suggested that PVC burden of more than 24% is associated with PVC-induced cardiomyopathy in patients without congenital heart disease. So in children with congenital heart disease, they are observed about 20 to 30%. And then VSD are associated with PVCs by the study done by Banerjee et al. In 2022. Banerjee also found specific conduction problem in specific problem like atrial fibrillation is common in ASD, AV valve canal defect associated with AV block, tetralogy of Fallot associated with ventricular tachycardia, TGA associated with complete AV block, and Epstein anomaly is associated with supraventricular tachycardia. What about in adult? PVCs are relatively common in adult with congenital heart disease. Their prevalence can be higher compared to the general adult population due to the underlying structural abnormalities and surgical intervention that this patient have gone. So the frequent or symptomatic PVCs in adult with congenital heart disease may indicate underlying issues such as increase in erythrogenic potential or heart failure. So the presence of PVC in adult basically can be seen as precursor or risk factor for more serious arrhythmias such as VT or VF. So the mechanism basically there is irritability and remodeling. So this PVC can lead to electrical remodeling of myocardium, which may create environment conducive for the development of more sustained arrhythmias like VT and VF. PVC can act as a starter as well. So in patient with heart disease, the scar tissue from the previous surgery or from ischemia, PVC can initiate or exacerbate VT episode. So on top of it, PVC also increase erythmogenic potential. The study has shown that PVC can increase the risk of developing more complex arrhythmias. This particularly true in existing structural heart abnormalities, especially those with previous cardiac surgeries. On top of it, adults with congenital heart disease who had frequent PVCs were at increased risk of VT, particularly when the PVC were associated with structural heart disease, which Miller et al. Echoes the finding in 2019. Okay, in Eisenmenger patient, the PVCs are relatively common, and then this often related to the underlying structural and functional changes in the heart due to the syndrome. Indicate the increase of arrhythmogenic risk due to the altered hemodynamics and potential right ventricular stress. The frequency and pattern of PVCs may reflect the degree of ventricular strain and overall cardiac health. What about the mechanism? So that when there is right ventricular strain, This chronic pressure overload on the right ventricle and subsequent dilatation and remodeling can create environment conducive to the arrhythmias, including PVCs. Electrophysiological changes in Eisenmenger syndrome often very significant degree of hypertrophy in the right side and fibrosis, which can disrupt the normal conduction. And on top of it, the pulmonary hypertension also cause elevated pressure and then resulting right to left shunt, and it can affect the heart function as well, making PVCs more likely. On top of it, PVC also affect the cardiac function in congenital heart disease. The Liska et al. Studies in the retrospective study influencing the ventricular ectopic beats noted that the PVCs burden more than 1% affect the cardiac function in the systemic ventricle during the long-term follow-up. The mechanism basically, when patient had frequent PVCs, particularly those with bigemini and trigemini, this can lead to decreased cardiac output, basically due to reduced time for diastolic filling between the PVCs, which can compromise the filling and overall cardiac function. And then it also can exacerbate the existing hemodynamic abnormalities. So in the right ventricular outflow tract obstruction or ventricular dilatation, frequent PVC also can impact the time of filling and also time of ejection. And then the electrical remodeling that can happen during chronic PVC also increase the risk of arrhythmias and potentially worsen the overall cardiac function as well. So what about VT and VF in adult with congenital heart? The prevalence of VT basically common in adult with congenital heart, and then it can range from 10 to 30% depending on those specific condition and the severity. VF is less common than VT, but it remains significant concern due to life-threatening nature, but it's often associated with history of VT, severe structural heart disease, and or advanced heart failure. So the polymorphic VT and VF are associated with extensive myocardial hypertrophy, when there is presence of diffuse fibrosis, when there is history of myocardial ischemia, when there is severe systemic ventricular dysfunction. So in the study by Kyrie P. et al. In 2016, VTs are widely reported in TOF patients where monomorphic ventricular arrhythmias are the result of the ventriculotomy and a scar in the RVOT. In the study by Kyrie et al. As well in 2008, in TGA patient, half of TGA patient presented with monomorphic VT, and 34% patient presented with polymorphic VT, and 70% presented with VF. Alright. So mechanism of VT in adult with congenital heart basically the same with the other VT as well. First method is re-entry circuit, where VT often result from the re-entry from within the scar tissue and fibrotic areas, which can be common in patients who had previous surgery or significant structural abnormalities. Or it can be trigger activity by the PVCs or other arrhythmic activity in the context of heart problem. Okay, so VF may arise from the substrate where there is multiple rapidly firing ectopic foci in the ventricles, causing VF. So Besser et al. Noted patient with congenital heart disease associated with higher risk of arrhythmias and sudden cardiac death. So Besser divide this patient into two groups basically. One group is the discrete mechanism where there is reentrant monomorphic VT, and there's a second group basically with more diffuse substrate, and this group basically has higher risk of sudden cardiac death. This is the graph showing the type of ventricular arrhythmias and risk of sudden cardiac death in adult with congenital heart. So in anatomical macro re-entry that causing monomorphic VT, the group include your VSD, pulmonary stenosis, double outlet right ventricle, the TOF PA and TOF, will develop more of monomorphic VT, but the TOF patient has higher risk of sudden cardiac death compared to the VSD patient and PS. But in the other group B, which more severe, such as CCTGA with VSD, congenital aortic stenosis, Epstein anomaly, They have more scar-related focal micro-reentry, and then they are more likely to develop polymorphic VT and VF. Okay, so sudden death basically a very prevalent cause of death in congenital heart disease population, in between around 0.09% up to 0.26% annually. But compared to the age matched general population, it is much higher in adult with congenital heart disease. So sudden cardiac death basically is the outcome of the ventricular arrhythmia, but less than 5% is basically because of AV block. So the meta-analysis in 2000 congenital heart disease patient with ICD that will follow up for 3.5 years, about 24% receive one or more appropriate anti-tachycardia pacing or shock. This showed that there about 50 of them developing the VT or VF that needing the shock. Okay. The study and the design study that was done by Vermeer et al. In the prevention SAHD study come up with risk score to basically to identify which group of patients have more risk of developing sudden cardiac death. So if you can see the risk factor for the that been used currently, the coronary artery disease, the heart failure symptom, NIHA class 2 and 3, patient with history of supraventricular tachycardia, patient with impaired systemic ventricular function, and patient with impaired subpulmonary ventricular function, with QRS duration more than 120 millisecond, and QT dispersion more than 70 millisecond. So even at one risk factors, Eisenmenger syndrome has highest risk of sudden cardiac death at 4%. If have more than 4 risk factors, Eisenmenger have more than 25% chances of developing sudden cardiac death compared to the close ASD or tetralogy of Fallot. The top 3 is Eisenmenger, cyanotic non-Eisenmenger, and Epstein anomaly. Alright, but for Fontaine, they cannot do the 7 risk scoring. They only do 6 because Fontaine don't have a subpulmonary ventricle, which is one of the criteria as in the risk scoring. So the management of this chronic heart disease patient with ventricular tachycardia should be investigated. Other than their own congenital heart disease substrate, the other factors such as coronary artery disease should be investigated. That's why we send the coronary artery disease screening in our patient. And then we also look for any ventricular dysfunction, any long QT syndrome, or any erythromogenic cardiomyopathy, and any syndrome that are related to malignant arrhythmias. So management include the usual 12-lead ECG and the Holter, electrophysical case study to map the electrical activity of the heart and to identify the erythmogenic pathways, and then cardiac MRI to assess the myocardial fibrosis, then to identify the scar tissue that may be the substrate for the arrhythmias. On top of it, MRI also to evaluate the cardiac structure, to see the chamber size and the ventricular function as well. So the management may include the beta blockers, basically are the first line treatment for ventricular arrhythmias. But in our patient, we are unable to use the beta blockers because of the underlying bronchial asthma. So we opted for verapamil. So verapamil works by blocking the calcium channel, which inhibit calcium influx into cardiac and smooth muscle. So this result in decreased cardiac contractility, reduce heart rate, and slow conduction through AV node. So other agents include your flecainide, propafenone, and sotalol as well. Amiodarone often reserved for more refractory cases of ventricular arrhythmias. It is more effective for ventricular tachycardia and VF, but it has more complex side effect profile. So the indication for catheter ablation if the symptoms are recurrent and symptoms are frequent, and then if they are not well controlled with medication, as per European Society guideline, those with recurrent monomorphic VT or incessant VT or any electrical storm that are not managed through medical therapy, the catheter ablation is indicated. So in a patient with high risk of sudden cardiac death and patient with had history of developing sustained VT, so they are also another indicator for catheter ablation. And patient with post-surgical scar and individual who have undergone cardiac surgery and have developed scar tissue that may contribute to the arrhythmias, and then catheter ablation also can target these areas as well. And then also patient with complex arrhythmogenic substrates where due to multiple arrhythmogenic foci, so catheter ablation can help address the specific area within the heart. So in a systemic review, catheter ablation therapy in the TOF with VT. So patient who has undergone catheter ablation, only 1/5 of them requiring repeat catheter ablation, and the mortality rate was 0. And then only the mortality rate over 6 years follow-up only was 3%. And then the need for anti-arrhythmic drug was substantially reduced after the procedure. And then the percentage of usage of amiodarone and beta blocker also reduced significantly after catheter ablation. This was a study by the Evangel in the catheter ablation with patient with TOF. Alright, so I'm moving on to the last discussion on self-monitoring ECG. So basically it's a handheld single ECG to monitor patient for cardiac arrhythmias, and then it is now widely available for the use of patient and clinician. The difference between this device are multiple, but include variation in software and also device connectivity. Some are standalone, some are smartphone operated, some and also different in hardware. So handheld one lead ECG device rely on the capturing ECG signal and registration to lead ones, similar to the lead one of the standard 12 lead ECG. So basically these are obtained by holding two metal electrodes with two hands with multiple finger of each hand. So the first FDA approved device is the mobile by AliveCore. So the sensitivity is about 0.82% with specificity of 99% in the community setting. In hospital setting, the sensitivity a bit higher at 91% and specificity about the same, 97%. So about 33.7% more sensitive to detect arrhythmias compared to the traditional external loop recorder. So beside atrial fibrillation also can be used in other rhythm and conduction disorder that can be detected through one lead ECG. So PAC and PVC can often be well discerned with one lead ECG signal. But there are potential pitfalls. AF also can be sometimes difficult to distinguish from frequent PACs in one lead ECGs. So atrial flutter also can be challenging to detect through one lead ECG because that typical sawtooth pattern best seen in the inferior lead of V1, and while one lead ECG is comparable to lead 1 on 12 lead ECG. It is not very useful in detecting specific ventricular pathology, but it was previously suggested that lead 1 can be useful to predict the site of origin of idiopathic ventricular arrhythmias. A single lead registration is not useful in excluding acute coronary syndrome or MI. So it should not be used for these purposes. Other FDA approved wearable devices include your Apple Watch. The studies noted 34% of 450 participants received irregular pulse notification that end up being diagnosed as atrial fibrillation. The Apple Watch has different method of detecting. They use the PPG, which is the photoplethysmography sensor, to detect the irregular pulse. Other device include the Zio patch. This is the 14 days adhesive device that can be worn over the left pectoral region. So it records 3 lead ECG strip and then sent to Zio patch app for analysis. So the study noted comparable result compared to the Holter monitor for atrial fibrillation. Another single study also reported significant arrhythmia, about 10.5% of emergency department visit with unexplained syncope when patient fitted with zero patch compared to 2% with stranded posita. The last device that are approved by FDA is the ECG check. This one also almost like the cardiac mobile. It's a single electrical stressing. Same as well, 30-second rhythm strip that can be uploaded to the app as well. So the study about the same with 900% sensitivity and 97% specificity to detect AF and atrial flutter. So the take-home message for today's discussion that patients with frequent and symptomatic PVC may experience symptoms such as palpitation, dizziness, or even syncope. So PVC also can affect the cardiac function and warrant closer evaluation. Frequent PVC also can reduce the efficiency of heart pumping action, and then also may exacerbate the heart failure symptom. The long-term effect of chronic PVC may contribute the progression of heart disease in the patient with congenital heart disease, and then may have high risk of developing arrhythmia such as VT. And arrhythmia is very common in our congenital heart disease population, and sudden death is among the most prevalent cause of death in CHD population. Self-monitoring ECG is very helpful device to help monitor patient at home and assist clinician in management of the patient.